Good morning, everybody. Thanks to you all very much for coming to our third symposium in colorectal diseases. And this year is special that we moved from Phuket to Bangkok, and still we have lots of fan clubs coming with us for this third time. And my talk is going to be about the management of ruptured sigmoid diverticulitis in emergency settings. As we all know that the incidence of diverticulosis is around 20 to 30% within the population over the 60 years of age, and among these, 20% would develop diverticulitis and ruptured. And it's quite a big problem, even especially in the States, that around 300,000 admission due to these problems each year, and that would reflect lots of money for each year on spending on solving this problem. And we all know that the imaging study for this condition would be the contrast CAT scan imagings. As you could see from the image here, that free pneumoperitoneums could be seen around the edematous sigmoid colon. Once we see the scans, we go back to our classical Hinchy classification, and today's talk would be specific on Hinchy stage 3 and 4, which means the purulent drainage or peritonitis and fecal contamination to the peritoneal cavities. In the old day, and perhaps among us, some of us still practicing using Hartmann procedure, and some of us would go for an open Hartmann procedure for this kind of problem. And that's nothing wrong with that, because the predictors for making this procedure, the Hartmann procedure, is of course the emergency setting for the cases, and usually these cases would come in the middle of the night, and the BMI over 30 and the degree of contamination, of course, it would be purulent, and sometimes would be fecal contaminations, and the immunosuppression patient, and Hinchy grade 3 and 4. But I would like to show some evidence, perhaps to change your mind of looking after this kind of patient, this group of patients later on after these sessions. The first literature that quite interesting to me is to compare stage 1 and 2 stage operations with, to treat these conditions. The report gathered 98 published studies and 1,051 patients back then in 2004. They all went to Hartmann procedure. And you could see the mortality for Hartmann procedures is, it's around 20%, which is very high. And wound infection at 30%, that's not surprising. Anastomotic leakage is 4.3. And these actually not only including the number for Hartmann procedure itself, it's also including the number for the reversal. The bad part is actually not the Hartmann procedure. The bad part is the reversal of Hartmann. And see this number, the primary anastomosis for this open resection and primary anastomosis cases, 569. The mortality is half, 9.9, and wound infection 9.6, and anastomotic leakage is quite high back then, 13% as compared to 4.3% here. So primary anastomosis seem to be safer for the patient, especially for if we think about the second procedure, the Hartmann reversal, which would carry a very high mortalities and complications. And another thing to look at is once we perform Hartmann procedure for the patient, around 50 to 60% of the patient would never come back for the reversal. It might be that the mortality and complications related to the heart map reversals is quite high. So most of the surgeons would refuse to reverse the heart map for the patients. These numbers is actually confirmed by this randomized clinical trial, including 62 patients in all acute left-sided colonic perforation, Hinchy 3 and 4, around 2006 and 2009, report in 2012. And all these patients plan to reverse within the stoma in 3 months' time after the surgery, the first surgery. 30 patients went for heart map procedure. 32 patients would go for primary anastomosis with loop ileostomy. So they compare primary anastomosis, but this one with loop ileostomy to protect the primary colonic anastomosis. Interestingly, 90% of a patient with ileostomy, of course, would be reversed, and 60% of the colostomy for heart map procedure was reversed. This is the number for the first surgery, heart map procedure, and the primary anastomosis with loop ileostomy. So you could see that for the first surgery, the ruptured and emergency surgery, as you could see that the number for these two groups are not quite different. They're all the same. Operative time, blood loss, and hospital stays and complications after the surgeries. But if you looked at the second procedure, heart map procedure reversal and ileostomy reversal, you will see that the operative time duration for heart map reversal is significantly higher. Hospital stay with higher complications is higher, and the rate for the reversal is much lower. So to pick the procedure at first for these Hinchy 3 and 4 is very important, especially if you pick heart map procedure. I'm sure in some cases you would have to think of doing the heart map procedure, but if the contamination could be controlled and the patient is well enough, so we should think of the primary anastomosis, and if you're not sure enough, sometimes we should add up the loop ileostomy for the patients. And another challenge that I would like to introduce here during this talk today is that since the laparoscopic surgeries is quite widespread nowadays, so why not introducing this laparoscopic surgery for such a group of patients? The rumor in the old days, we might be thinking of the spread of the contamination by using the pneumoperitoneum, or it would be difficult to control the contamination during the procedure using the laparoscopic approach. Let's see the evidence here. Laparoscopic approach to the treatment of the sigmoid diverticulitis. In this case, they combine all cases related to the surgery for diverticulitis in 3,868 patients. And the number that we are interested in is complicated diverticulitis is about 12.4%. And they divided into 3 groups of surgeons, high volume, more than 100 procedures enrolled, 30 to 100, and less than 30 procedures enrolled to the study. As you could see that the duration of the overall laparoscopic approach is significantly less in high volume surgeon cases. And the incidence of Hinchy 3 and 4 that we're talking about today is only 1.8, which is 28 cases in this study. And the perforation, and as you can see here, for group 1, which is high volume, they do more on advanced perforation cases using laparoscopic surgery. And the conversion rate is less, but fairly the same for all groups. And the mortalities and complications is actually comparable in 3 groups. So there's a trend that for high volume surgeon, more experienced surgeon, they would try and having more confidence to proceed with these complex laparoscopic surgery, and the outcome was not too bad. And this is another recent study reported in 2016 of 260 patients, and 28% of these patients are complicated disease of diverticulitis, abscesses, perforation, fistula, stenosis. 21 cases with perforation, and 90% of all these cases would be resected with primary anastomosis. This table is the operative details on both complicated and uncomplicated diverticular diseases. As you could see that, of course, if you do laparoscopic surgery on difficult cases, it would spend significantly more operative time, and the conversion rate is a little higher, and the length of bowel resection and the complication, luckily, is the same. And the post-surgery recovery was much faster in uncomplicated diverticulitis, but within this group of complicated diverticulitis, the numbers is not that bad. Gases mean like the bowel function was around 2 days, and the length of hospital stays is 5 days. So for Hinchi 3 and 4, I think primary anastomosis is the first option of the procedure to think about during the surgery for this group of patients. And laparoscopic approach, even though the majority of patients would come in the middle of the night, but if we can provide or give the service of laparoscopic surgery for this patient, the outcome would be way better as compared to an open surgery. Let's look at our number from Phuket. A couple of years that we gather all the information of all the patients coming to our services. We do 100% laparoscopic surgery, and the majority of the patients of ours would come from all over the place, and mostly from overseas. Around 82%, 85% are from the other countries, mostly European population. We had 13 cases, and 75% was diagnosed ruptured of sigmoid colon, and around 17% descending colon diverticulitis ruptured. All of these patients would be Hinchi 3 and 4. 67% of the patients are male, and the age around 54, and then the BMI was 32. So we did total laparoscopic approach for all these patients. We make sure the distal margin would be involving the upper rectum, so we are not leaving any diverticulosis. We do colonoscopy to check on the pouch, and at the same time to check that there's no residual diverticulae on the distal end. And then we would avoid for the proximal end of the anastomosis to avoid any of the diverticulosis if possible. And after all the procedure, after the double staple technique anastomosis, we do colonoscopy to recheck on the anastomosis and make sure that it's airtight and perfect for the patient. So there was no conversion. We spent about 3.5 hours on each patient in average, and the hospital stay was around 7 days. So in conclusion, I think laparoscopic approach nowadays is feasible and safe for the patient, and to perform primary anastomosis for the majority of the cases of an acute ruptured diverticulitis in G3 and 4 is preferable for at least our group. Thank you very much.